It is my pleasure to present to all of you, just before our award ceremony, the newest or one of the newest additions to the SUNY Downstate team, our amazing and wonderful president, Dr. Wayne Riley, came to us from Vanderbilt, I believe. Is that right?
That's correct.
And he has been here, I think this is 1 month, 47 days. And he is here representing our administration, and I hope you have lots of questions for him. I hope you also enjoy his speaking as much as I have. He's always brought insightful thoughts to the medical school every time he speaks to us. Dr. Riley.
Thank you, Eric. Thank you very much.
Yes.
Well, good afternoon. Welcome back home to Brooklyn. As Eric just said, I'm 47 days in as the president of this great academic health science center. I was unanimously elected on January 24th by the trustees of the State University of New York after a 10-month national search. There were over 70 nominations for this wonderful opportunity, and I'm eternally grateful for the honor of a lifetime to lead your alma mater. I know this is a great time to be back and to be in reunion. This is a great alumni association. I want to salute your illustrious president, Dr. Monica Sweeney, who, by the way, is a member of my transition team. I appointed a transition team, and I specifically wanted to make sure that the alumni were represented as they advised me on the first things that I should do during this very critical 6 to 9 month beginning of my tenure. So I want to thank Monica. She represents you well. And I really do treasure the associations that I will be developing with this association with an alumni. I know there's a number of alumni faculty here. Dr. Libyan is just one of them. Who are our faculty who are here? I know we have several. Yes? Great. Well, thank you. We have great faculty who are committed to Downstate in their faculty role. So that's the other wonderful thing I've learned about Downstate is the number of people who have gotten their medical education here, maybe their residency education here, and then have remained on the faculty, which I think speaks volumes about how folks feel about their institution. I won't talk long, but I will sort of give you some impressions that I have and some ideas that I have going forward. The first thing as I was walking over here, as I mentioned, I was selected on January 24th of this year to become president. And within literally 20 minutes of the public release of my appointment, I was getting email messages from all over the country from Downstate alumni who knew me through my various capacities of professional life. I'd been president of the American College of Physicians. I'm a member of the Institute of Medicine. I chair the section on health administration there. I've served on the faculty at Vanderbilt, Baylor, Meharry, et cetera. And I was stunned, colleagues, at the number of people who I did not know had connections to Downstate, that they were alumni of Downstate, they trained here, they were on the faculty here at some point in their career. And so to me, that is a clear manifestation of the greatness of this institution. The fact that your alumni are all over the country and the world. Now, we're quintessentially Brooklyn, quintessentially New York, and we embrace that because as I was in Albany on Monday telling members of the governor's staff, this institution is responsible for supplying a large cohort of not only physicians who serve the great state of New York, but nurses, PAs, therapists, et cetera, et cetera. And so that's the value proposition I have to continually raise with the folks in Albany, that this is your jewel of a state university health science center. And again, it just got validated within an hour of my appointment of how the alumni and the great products we put out by our faculty really do make an impact in communities. Second observation is sort of related to that. I've gotten some critique from some of you who say, I never hear anything from Downstate. I never get a piece of mail. I never get an email. I never know what's going on. I only hear about the bad things. And so I take that as thoughtful critique that we have to do a better job of communicating with you, the alumni. I had one alumnus, and she is a very distinguished physician in her own right. Her husband, I won't say the name, but her husband happens to be the dean of a very prominent private institution here on the East Coast. And I was at a cocktail party with her, and she said, I'm a Downstate graduate. And I said, I didn't know that. And she said, and I never hear from Downstate. And I said, well, I have to begin to work on that. And I said, thank you for that information. And so I'll be talking with Dr. Sweeney and the alumni leadership to figure out how we can better connect with our alumni across the country and across the world. It may be something as simple as me sending out a yearly president's report to the alumni. I know many institutions do that. I did that in my prior presidency. The alumni loved it. They felt like they knew what was going on. And so we'll figure out ways to better communicate our message. The second thing, I'll sort of tie that into the campus. The other observation I have about the campus, separate from the alumni, is Downstate doesn't tell its story effectively. I assure you, colleagues, there's a lot of good things going on at Downstate. But we've been a little too bashful about telling the world the great things that are going on, what our students are doing, what our faculty are doing, progress we're making in a number of areas, some of the things that we've contributed to over the years. And so that was one of the things I asked of the chancellor after my appointment. She said, what do you need to be successful? I said, well, it's easy, Madam Chancellor, I need money. She said, well, Dr. Rice, short of money, what do you need? I said, okay, Madam Chancellor. I said, one thing you can help me with is to help me better coordinate our communications and marketing efforts. And so she provided a firm to come down over the last week to begin the process of making some recommendations to us about how we can improve our marketing and our communications. Now, marketing is not just billboards, colleagues. You know, we all live in communities, and many of you work at academic institutions. The moment U.S. News and World Report comes out, they put up a billboard, or they tweet it, or they Facebook it, and all that. You know, marketing is more than that. And so it's the communication piece. It's what I call the east-west communication, a north-south communication of what we're doing at the institution. Because even in the institution, sometimes I find that people don't know the great things that are going on. So we're going to take a holistic view of how we better communicate, better market your alma mater going forward. So that's one of the other initiatives I've started within the first 50 days of my tenure. The other thing I can candidly tell you, I listened to the great conversation that was just had about sort of the state of medicine and healthcare, and it is concerning. We're in some uncharted territory with regard to the way that developments in Washington could have an adverse effect on Downstate and all the institutions, even where you work. You know, my impression, having dealt with this at the Institute of Medicine, is that medicine is going to be in chaos the rest of our careers. This is the new normal, colleagues. And so, you know, what I tell young medical students is, look, we can, you know, curse the darkness, but that doesn't get us anywhere in terms of what we have to do to take care of patients and communities. And so we're going to be heavily involved in some of the debates and discussions. I know I'm a little bit constrained because I'm an executive chamber employee of the state of New York, but in a non-political way, I can articulate, you know, some very basic facts that the extension of health insurance to Americans is not a wrong maneuver. We have serious concerns about the American Health Care Act. Every major medical organization in this country is opposed to it. Many of your specialty societies are opposed to it. The AMA is opposed to it. The American College of Physicians, which I led for 2 years, is opposed. The American Academy of Pediatrics, the American Hospital Association, I can go on and on. So we see this as a big problem in terms of all of our communities. And so we're not going to sit on the sideline in terms of the debate. I'll be headed to Washington in June to meet with the New York congressional delegation, first to introduce myself, but also to really press the case that, look, we have to protect some of the progress we've made under the Affordable Care Act. Now, I've had the opportunity during President Obama's tenure as president to visit the White House 3 times. And I distinctly remember the then President of the United States telling a group of physician leaders, look, this thing is not perfect. He told us that. It is not perfect. But he said, I had to make some accommodations to get this thing through the Congress. He wanted to do the public option. He said he knew that would have been a poison pill to get the bill through. The individual mandate was not something he really was, fanatic about, because he knew it had come out of the Heritage Foundation. But he compromised because he saw over time that we'd get more people insured. And so I remember the president telling us this in the Roosevelt Room, and he said, look, about 75 to 80% of this bill is good. There's another 20 to 25% we have to fix. And we know the things that we have to fix. And much of it rather, affects you. The narrow networks, your patients say they can't come to see you because this plan, you're not in the plan, all of that. But this was all predicted, colleagues, by the then President of the United States. But he expected that the Congress would work with him to repair the Affordable Care Act. But now we're at the point where, some of those gains in insurance nests, as I call it, are really at stake. So we have to be thoughtful about the way we approach some of the advocacy issues, particularly around Medicaid. Medicaid is an important program to Downstate. We take care of a lot of Medicaid patients. Those are the patients our students and residents take care of, both at Kings County and at the University Hospital of Brooklyn and the other affiliated institutions. So protecting Medicaid is going to be a challenge because of some of the dynamics that I just heard. The move to give huge tax cuts to most of us in this room will take money out of the Medicaid budget. So again, that's a clear and present danger to our historic mission of serving Brooklyn that bears some watching. The other thing we need to do is raise money more effectively. I think Downstate has had this reticence about asking for money because they thought no one will give us a big gift because we're a state institution. I can assure you, colleagues, that isn't true. The University of California, San Francisco just got a $20 million gift from an alumnus. University of Massachusetts, University of Tennessee Health Science Center. So part of it is I have to retool the way we think about asking for support. Yes, we are a state institution, proudly a state of New York institution. But the state of New York does not provide 100% of our funding to educate our students and residents. We have to generate clinical revenue. We have to sign contracts with institutions to provide care. And the other part, which again I think I really would like to address, is the philanthropy. We know there's grateful alumni out there, but for the fact if they were asked, they'd give a scholarship. They're grateful because their family has done well. They're at the point in their lives where they can make a substantial gift to name a building or endow a chair or all the other things that really are reflective of how you express your appreciation to your alma mater. So we'll be working with the Alumni Association on some of those initiatives. The second thing is our physical plant. One of the things as I was sitting back there, I thought, gosh, it would sure be great to have this meeting back on campus one day. Regrettably, we don't have a sort of conference facility where it would be nice to do, right, Sue? So, one of my aspirations over my tenure is to figure out a way to get some sort of conference facility on campus where all of you could be back on campus and you'd only have to put your head down on the pillows in this hotel, this very nice hotel, but that you're back on campus, that you can walk the halls again and reminisce and see, how the institution is progressing in terms of its physical plan. Folks do not feel the institutions are making progress unless they can see it, they can touch it, and they can sit in it. And so we have some great plans to really do some facility upgrades to the campus. The first thing we're going to do that I just signed off on this week is we're going to do a major renovation of Alumni Auditorium on campus. It is so heavily used for lectures, for orientation, for everything. And remember, it honors you, the alumni. So I've just signed off on spending approximately $750,000 to $1 million to renovate the auditorium because it is so heavily used on campus. And it is in honor of you, our alumni. So I think it should be gussied up and fixed up, new sound system, just sort of bring it up with the new technology. So I'm very happy we'll be providing more specifics through the summer on what we intend to do. But again, I think symbolically and from a functional point of view, that's the right thing to do. This auditorium is an alumni auditorium. It honors you, those of you who chose to come to Downstate. The final thought, and then I'll take questions, is I'm an internist, by the way. I'm a general internist by training, very proud general internist. And when I was a candidate for the presidency, Sue will remember, she was a member of the search committee that selected me. I told them as a total outsider, my diagnosis in part of Downstate was that it had a little bit of what I call Manhattanitis. And it's not terminal. It's a little advanced, but it's not terminal. And what I mean by that, facetiously, is that we should never aspire to be Cornell, Columbia, Mount Sinai, blah, blah, blah. We don't have to be those places in Manhattan to be great. We're Downstate. And the next time I hear students say, oh, I just go to Downstate, I say, wait a second, wait a second. We're Downstate. You're a Downstate student. I don't want our faculty saying, oh, I'm just from Downstate. I don't want our students saying, I'm just from Downstate. We are Downstate. And we don't have to be like those places across the water to be great. I've had the wonderful opportunity to earn 4 degrees. I got more degrees than the thermometer, my mother says. But I like school, and that's why I've devoted my life to academics. But no institution is perfect. No institution. If we're trying to get to perfection, we're in the wrong business. But all institutions can strive for excellence. And so my job on a daily basis is to be the catalyst to make your alma mater better and better. And I will never promise you I can make it perfect, but I do promise you we can make it better. And so that's the spirit in which I've entered this very challenging job at a very challenging time in healthcare. And I need your help. I need the help, the support of the alumni with a great team, great faculty to continue to advance this national treasure, and that is your alma mater, Downstate Medical Center. So with that, I will be delighted to take questions. President Sweetie. Thank you. Yes, sir.
Does Downstate have an
endowment? Good questions. Does Downstate have an endowment? The answer is yes and no. Let me explain something. Because we're a state institution, you're not allowed to have an endowment. But all SUNY campuses are allowed to have a campus-based foundation that's a separate 501c3 corporation. So the second part of that is no, but yes. The yes part is that the Health Science Center of Brooklyn Foundation does have an endowment. That endowment's about $125 million. A lot of it is restricted. In other words, there have been bequests from families. It's into the endowment, but it's restricted to scholarship support. So in other words, the interest off of the corpus that's generated funds a scholarship, funds a program, funds a professorship, et cetera.
Is that money protected, Doctor?
Protected in terms of? Legally, he could not do that because it's a separate 501c3 corporation with a separate board. I sit on that board of the foundation. We just elected a new board of the foundation. So because we're a separate corporate entity that is, whose only sole purpose is the charitable, quote, support of Downstate Medical Center, I don't think he would have, much legal standing to do such.
Is it possible for someone to give enough money to put a different name on Downstate? Like Dr. Riley, School of Medicine?
Yes, what's your last name? Yes, I think that's lovely. I think that would be a very elegant name, Doc, for our new place. Yes, that is possible. It will take some legislative two-step, but I've spoken to the chancellor. She said we are not as constrained in doing things like that as people would think. So if there were an individual who felt very strongly and very appreciative, and we would work with the chancellor to make that a reality. Yeah, let me go here and then I'll come back. Yes, yes.
You talked before about what happened under the Obama administration from his original proposal to the outcome. But one of the communications and publicity that hasn't happened is that there has never, I have never seen the full original proposal come out and talk about what had to be modified and what the original proposal was. And in talking about the problems with the present presentation, I think seeing the original proposal might be useful, and what was forced on them by the Republicans already that has damaged that. And you seem to have connections, so maybe you can...
Yeah, boy, that's, let's see, that was 2007, what year? 2010. And I remember attending a meeting of the transition committee after the then president had been elected, and there were various documents floating around about versions of various proposals, including then Senator Clinton's proposal, and I can't remember who else there were several proposals floating around the room that day, I remember, and we were all passing them around, leafing through them, and the transition folks were saying, which one of these do you guys like? Yes, I do think something like that exists. I can try to find that document and share it with Monica, and then she could distribute it to you guys. I know the Center for American Progress has put out one. I think Brookings put out another. Several of our organizations have put out papers about how to repair or refine the Affordable Care Act, many of the specialty societies. So I think there's a few documents out there we might be able to put our hand on for you.
Because of, as you said, they could have been poison pills that they
Right.
were out or went in because it was the Republicans who said, or the industries who said that that's not there, we're against it.
Right, that's right. And
Those need to be...
those need to be sort of fleshed out again.
and publicized. Because
Great point.
It's only going to be public opinion that's going to stop it.
Great point. Great point. There was a great piece in New York Times this week by my friend Mike Spar at Columbia that called for let people go into Medicaid as one possible solution, just a possible solution. It was a very thoughtful piece. It was Monday, I think, in New York Times by a professor at Columbia School of Public Health. So there's a lot of dynamism around this.
The other thing I mentioned before is, I think presently, there's one vote more needed in the state senate to get a single-payer health care plan through here in New York State, and the governor's signature. That seems to be something if we can get active on.
Sure. Yeah, State Senator Parker called me earlier this week. I did not know that bill had been filed, but he asked me my thoughts. I said, from my perspective, yeah, right. So from my perspective, it is a New York solution. It may not be a Kentucky solution, but I do think it's worth serious consideration for the state of New York. Great. Thank you for that. Yes, sir.
First, Frank Byrne, class of 77. Welcome, Dr.
Thank you,
Doc. Thank you for joining the Downstate family. 5 years ago, at our 40th reunion, Dr. LaRosa came to speak with us. He was greatly stressed. I felt very sorry for him. He seemed somewhat embattled and he resigned within the next week. We're looking for a better outcome after this reunion today, if you don't mind.
Thank you. Well, thank you very much. Thank you.
Absolutely. At the public university, I was privileged to be studying at the University of Michigan School of Business in the 90s.
Yes.
When they completed the first $1 billion plus public school capital campaign
right.
at the University of Wisconsin in Madison,
Yeah.
where I live now. We've been involved with them. They convinced alumni to give them $125 million not to change the name of the business school for just the next 10 years.
Wow.
So, I mean.
There's some creative things,
There
yeah.
are some great things
Yeah.
going on. You know, Downstate is a unique and wonderful, unparalleled experience. We were groundbreakers in terms of diversity of gender, age,
That's right.
and ethnicity in our class in the 70s. We had people as old as 48 starting medical school, and they were tremendous contributors.
I love
to the
that.
class.
I love it.
You know, and grateful but also amused that now people are looking at it as shocking news that 80% of the determinants that will decide whether you're in a hospital bed or
Right,
a
right.
home bed tonight are social,
Social, yeah.
not clinical.
Right.
I could have told you that as a medical student in 1973.
Because you were in Brooklyn, yes.
In Brooklyn.
Yes.
I'm sick of the Manhattan academic medical centers looking down their noses at us,
That's
going
right.
to Albany to lobby
Against us, that's right.
And we need to stop that. So this is a tough job. I hope you have it for a long time. In my life, I had one shot. I only applied to state universities in New York for medical school. I was fortunate. I grew up across the Verrazano Bridge,
Perfect.
getting here so I could stay home.
Great.
So I'm grateful for that.
Thank you. You validate why we exist. Thank you, Dr. Burns. Thank you. Thank you. Thank you for your comments. In terms of the philanthropy, yes, there is no reason why we can't do what Wisconsin, Michigan has done, several other state universities, but for the fact we have to shed our preconceived constraints. Let me go to the left. Yes.
Will Clancy, class 67, from the University of Wisconsin.
Yeah, great.
Professor there. That, at least in my class, I think the average cost of tuition downstate was $400 to $800 total for 4 years. Due to one person, Governor Rockefeller. One thing downstate lacks nationally is a name. Is a name. I hate to say it, but personally, I've always felt that we should be called Nelson Rockefeller Downstate College of Medicine. Because it gives us a national presence, also perhaps access to Rockefeller money. But what we have a generic name.
Yes.
We don't have a advertising name.
Yes.
And I would strongly suggest, you know, it's like naming a stadium, somebody donates money. By naming a name that everybody can connect to would be, I think, something we need to consider.
Great. I think you're onto something, Doc. There may be a guy in Albany named Cuomo who may have a different view, but no, I take your point very seriously. That again, that is sort of a I hate to use this old management term called out of the box thinking. Right. Yeah, that's right. Bloomberg even. But no, I think you're onto something. We have to think differently about naming opportunities, philanthropic approaches, et cetera, et cetera. So I hear you loud and clear. Yes.
Roy Weiner from the class of 67. Has anyone done a calculation to make education in downstate loan-free on a needs basis? What would it take in our endowment?
No, I'm glad you.
Graduate with no debt.
Right. I think you're onto something because the Governor Cuomo just got through the Assembly, the Excelsior Scholarship Program, which, as I understand, they gave us a briefing on Monday in Albany. Any college student, and this I'm just drawing the parallel here, any college student who attends a SUNY campus, their family's median income is no more than $125,000 a year, will go tuition-free to any SUNY or CUNY school for their bachelor's degree. So could we do that in medical or health professions education? We're going to study that. We're going to absolutely study that to see if we can mirror or develop a program that mirrors what they're doing for undergraduate education in the graduate professional schools. So that's a topic of discussion that all four SUNY medical schools will be having sometime in the next few months, whether we should try as a group. Remember, there's Buffalo, there's Upstate, there's Stony Brook, and then there's us. If we as a group should put in a proposal to do something just like that, because I too am worried about the high debt loads of some of the students have to assume. Now think about it. You get a Brooklyn kid whose parents are blue collar. They make a good living, but you know the prospect of $50,000, $60,000 in debt times 4 years. Then if you do a residency, the interest is clicking, by the way, during 3 or 5 years of residency training. And then before you even buy your first house, you've already got a mortgage in essence. And this is the problem we're seeing with some students in their specialty choice. I know that there are students who came to Downstate to do pediatrics, but when they started doing the math, these kids are very smart. And they said, my gosh, my debt, maybe I shouldn't do pediatrics, I should do something else. But we need, and not that we don't need specialists. I know many of you are specialists. That's not what I'm saying. But I'm saying we know we have huge issues in terms of primary care specialties, pediatrics, general internal medicine, family medicine, in some cases OBGYN. So we need to have a good, healthy cohort of our students who pursue those careers. Again, we need pathologists, we need ENT, we need urologists, we need all of it. I will never pit specialty against specialty as president, but I will articulate that we do need to look at the issue of debt and how debt sometimes can have an overly steering effect on specialty choice. Yes, sir.
We also need excellence in medical education, and our increased cost and the debt we carry impacts on the availability of quality teachers and researchers in medical.
Absolutely. Well stated, Doc. Well stated. Let me go here. Yes, sir.
A student who showed us the hospital yesterday on the tour said that there's a program in place now that you have to pay tuition. But if you work in a state institution, any place in the country, for 7 years after graduation, your debt is wiped out after the 7th year. So there is some kind of program.
Right. There are, and how many of you from California, for example? I know California has one. Several states have something similar to what you just laid out, Doc. So again, New York State even has that. The state of New York has what we call loan forgiveness programs. And what happened during the recession, though, remember we were sort of getting GDP growth to more happier levels. A lot of state governments cut those programs, and it's taken a while to reactivate those programs. So those are great programs for some students. I would never say they're perfect for every student, but we always make sure our students know about those programs as they make decisions about how much debt to take on for their medical education. Let me go back there. Yes, Doc.
So welcome, Dr. Riley.
Thank you very much.
I'm Janine Downey, class of '92.
Thank you.
Looking at recruiting younger doctors into the practice of medicine, I wanted to know what your views were on maintenance of certification and having to take the boards every 10 years.
Oh my gosh. Yeah, I just had to deal with that as president of ACP. How many of you internists in here? You guys heard from me a lot, didn't you, over the last 2 years when I was president? Let me set my downstate hat aside and wear my president emeritus hat as, of the American College of Physicians. As professionals, we have to be committed to lifelong learning. The problem we saw at the American College of Physicians was that the recertification process had become too onerous, too difficult, too time-consuming, too high stakes, and there was no educational data to back up what the American Board of Internal Medicine was then articulating about. And the ABIM did the same thing as the American Board of Dermatology, and all the boards kind of, they're a little bit of a cartel, obviously. But when you reduce it down to its concept, my view as a medical educator is that we should not use the recertification process solely as a means of denying hospital privileges and credentialing privileges for health plans for physicians, particularly after they've been in practice, for 10, 20 years. I do not believe that doctors get stupid the day after they pass their boards. What happens is, and us internists know, and I'm sure the specialists know as well, the practice of medicine has changed, that we're less called upon to be generalists in a sense. That even in cardiology, how many of you are cardiologists here? The cardiologists know. There's very little general cardiology anymore. There's left ventricle cardiologists, and there's right ventricle cardiologists, right? And I'm being facetious, but even in our subspecialties, they're slicing and dicing it so much that there's no reason to. You don't see heart failure patients anymore, or you don't do caths anymore if you're a right ventricle, left ventricle guy or gal. That's the way medicine has changed, even in oncology. How many of you are oncologists here? Oncology's changed that way. You know, there's docs who just do, leukemia, lymphomas. There's others that do solid tumor work. And guess what we do for our families? You know what you do for your families. If your mother, your brother, your sister, your cousin calls you and says, look, I have X, what do? We know in our hospital who the guy or gal is who's best at X. And I say, you go see Dr. Smith. She is the best at leukemia. I don't care that she doesn't take care of blood dyscrasias. She's good at that. So that's the issue with recertification. It's not kept up with the fact that the way that medicine is practiced now. And so, that's something that I know we'll talk about among the chairs, because the chairs, I think, ought to be part of the national discussion about maintenance of certification. Yes.
At their 1040s about 3 years ago, they were hoarding about $12 million, almost $13 million of the board certified dermatologist money. And from all of our perspectives that have to keep giving money to maintenance and certification, I truly do feel like they're the new mafia. And CME was fine for my mother. And
I can tell you, those internists will tell you that the American Board of Internal Medicine had, I think, reserves of 35 to 40 million. Yeah, I know. Yes, I've had many skirmishes with Rich Barron. I've had many skirmishes with Dr. Barron. But so your point is germane, and so how does it relate to Downstate? Is I want our clinical chairs to be part of that national discussion. We have got our distinguished chair pediatrics back there. I know he goes to the pediatrics meetings. Downstate has to be at the table for these more macro issues. Again, another diagnosis I've made is we have to be more outward facing, meaning us, the faculty and staff, and go these national meetings, get on these national committees, deal with national issues related to healthcare broadly more vigorously. So thanks for that. 2 more questions. I know they're giving me the hook here. Yes.
Congratulations.
Thank you.
Thank you for joining the faculty and staff and running this place. Have you thought about, I flew in from Colorado, and I didn't get a cab, but I used Uber. Isn't medicine right for disruptive changes where you don't have to go to classes, where you could triple, quadruple the size of classes and do them remotely? I mean, I suspect that the school here is like the schools that I've been involved in. Students don't go to class that much anymore. They actually get the notes, they can video link in. Why do you think now we're not even a leader of disruptive technology and change? Right. We could triple, quadruple the number of students we have.
No, I think, you're right. You've touched on sort of a mega trend in all of education, higher education in general. Remember, we're part of higher education. And to your point, the curriculum that's probably the most resistant to change is medicine. Nursing is doing it. Our nursing, remember, we have a College of Nursing, very fine one, at Downstate. They have a hybrid online BSN program. It's for folks who have bachelor's degrees in sociology, whatever, and decide they want to be a nurse. That program's 50% online. We have other programs online. So the next frontier is sort of migrating some of that hybrid. Now, there's totally online, and then there's hybrid. So hybrid is sort of 50% online, 50% in the seat, or some permutation. So the educational data suggests that students actually are more successful in a hybrid model that there is some value in being in Dr. Libyan's lab, looking under the microscope with her, as opposed to just seeing it on a video screen. So this is the challenge that our chairs have working with our dean, is to really continuously look at our medical education curriculum for areas where we can do some innovative things. And I think that innovation is very important. Now, even let's take the teaching of anatomy. There are some schools that are getting rid of gross anatomy. Now, gross anatomy, we can all tell war stories about gross anatomy, can we not, colleagues? How we're in the gross lab till 5, 6, 7 in the morning, right? You remember those days. And you go home and you smell like formaldehyde, and I remember that too. Well, some schools, they got rid of that. They're doing it all electronically. 3D imaging. The kids are wearing these, the virtual reality thing some of your grandchildren are walking around with, They're doing that in anatomy labs. So I want us to be thoughtful embracers of some of that new pedagogy. Thank you. Last question. I know that I'll get the hook and, yes.
Dr. Riley, I'm Celia Divino from the class of 1992. I'd like to segue a little bit from philanthropy and talk about the support for the medical school. The usual paradigm for academic medical centers is that the clinical departments do support the medical school significantly, up to 25–30% taxes. Unfortunately, I belong to that group because I am, one of those members of the academic community across the Bay. I'd like you to share with us your thoughts and your strategy on how you intend to strengthen the clinical core of the university. I trained there when it was a real force with tentacles across all institutions from Brooklyn. And I think the potential is there. You are in a borough that is probably the most populous borough of New York. And patients stream across the 3 bridges. I'm a beneficiary of that. What is your strategy to grow the clinical program of the university, the hospital, because the downstream revenue and benefits of that is inevitably going to go to the medical school and the reputation of the medical school?
Great question. That in baseball parlance, that's a high, hard one. This is, let me level set here. Brooklyn, listen to this. I heard this the other day. It's still sort of resonating with me. Brooklyn has 2.6 million people. If Brooklyn were its own city, we'd be the 4th largest city in the country. Think about that. Wrap your head around that. And the diversity of Brooklyn in terms of racial, ethnic composition is equally impressive. The problem that Brooklyn has in terms of healthcare facilities is that all of them are losing money. Brookdale's losing money. Health and Hospitals Corporation, which runs Kings County, which many of you rotated through, is losing $1.8 billion. They're going to have to make some significant cuts after the mayor's election. They can't do anything until after Mayor de Blasio is reelected, for the obvious reason. So they're struggling. Brookdale is struggling. Kingsbrook is struggling. Interfaith is struggling, et cetera. And then our own hospital, University Hospital Brooklyn. It's struggling. It was built in 1966. How many of you were here in 1968? It was a brand new hospital then, wasn't it, guys? Right? Wasn't it brand new, sort of state of the art? Not much has been done to it since then. And that's the problem. We're running a 1966 chassis adult care hospital, that's getting increasingly difficult to patch up. And so our issue is our clinical platform. Downstate, Kings County is obviously a key affiliate, but think about it. If they're retrenching because of deficit, and the other facilities are retrenching because of deficit, you could see that we have some clear and present danger that's top of mind for me. We're going to have to think very creatively. I think it's going to be increasingly difficult for me to convince the governor to keep supporting us because of our inefficient clinical platform, i.e. Universal Hospital Brooklyn. And when the chancellor hired me and the chairman of the board, I had a conversation with him, I said, look, Mr. Chairman, I can bring you a plan for a $900, $800 billion brand new hospital for Brooklyn. And he kind of reared back and I said, I know that's dead on arrival. But I said, the point I'm making is we're going to have to do something different about University Hospital Brooklyn. And I don't know what it is right now, colleagues. I'm pretty agnostic about, well, endowment takes a while, I agree. But if I were to get a person of means, that would be a perfect naming opportunity. The new, what's your last name again, Doc? Yeah, Doc, the new, I like that. I can see it in lights. So, right, that could be a philanthropic play in terms of a new hospital naming opportunity. Because, again, I'm very worried about University Hospital Brooklyn because it's just old. And many of you practice in other parts, you practice in Manhattan. They have a building going up every year where you are. I don't know where you are, but I assure you they're building a building every year wherever you are. So, you know, that is going to take a lot of work by the chairs, the administrative team, the chancellor, myself, because I think it would be, it's a difficult proposition for me to think that in 5 years we still have University of Brooklyn in the way that it is now. I'll say it that way. I won't go any further than that because that's very complicated, but I think that would be very dangerous to the viability of our programs if we don't do something in the 5 to 7 year period about University Hospital Brooklyn. Great. I could keep going, but they're pulling folks.
I know that many of you have questions for Dr. Riley. I know also that we have an award ceremony and a luncheon, but Dr. Riley, his first order of business before he even came to Downstate was to make sure that he had a clear glass door on his office door, which represents the fact that he is extremely approachable and he is very responsive, and he has a new assistant, Yesenia, who is also very responsive. So please contact the Alumni Association or his office. He will answer your questions. He's amazing. And with that, I really want us to give him a round of applause for coming today.
Thank you very much. Thank you. Let me tell you about that door. When I was a candidate for the president, she heard me say this. They took all the 8 finalists through the school, right? And you may not have been on campus in a while, but you walk down the hall where all the big shots are, as we say, and everybody's behind these kind of doors. You see that? They're behind that. And I said, why are we behind doors like that? I mean, there's nothing going on in the president's office that needs to be walled off. So when I got the job, I said, first order, get rid of that door because it sends a bad message. And we're changing all the doors in that hall. I just signed off on, we're going to go right down that hall and change all those doors because it does not send a good message about my role is not to be walled off behind a door. It's to be engaged with the community. And our administrators need to be engaged with the campus, with the students, the faculty, et cetera. So symbolic, but important.
Thank you. Yeah. Thank you. Thank you, Dr. Riley. With that said, I do want to let you know that Dr. Riley is on the same page as I am. I started 2 years ago and 1 month, and I was told that we had to pay for a new door because we're a separate charity from Downstate. So our door is open every single morning and open all day long so the students can come in and out because a closed door doesn't say come and talk to me about how you need help. And we were the only door on that hallway, and I kept saying, that's a fire hazard, and I said, have the fire marshal come talk to me. And so our door is always open. So